Okay, this is the second part of liver, and we finished talking about complications, particularly hepatic encephalopathy and a little bit of hepatorenal syndrome. This slide that you see here is an overview of what happens to the patient who develops cirrhosis. Basically, it starts with liver inflammation that produces liver necrosis. Along with that inflammation, there's typically some pain and fever and some GI symptoms and some fatigue. Oftentimes, if the inflammation is just one time, then it subsides and the liver regenerates and all is well. But if it's a continual inflammation, as occurs in chronic alcohol use or chronic hepatitis, then that liver necrosis produces liver fibrosis and scarring. The fibrosis and scarring is an architectural problem. It affects the structure of the liver, and it doesn't allow the blood to properly move through the liver. The liver becomes like a sieve with the holes all clogged up. You end up with portal hypertension, which is increased pressure in the veins that drain the GI system, all ending up in the portal vein. And you get backup of pressures in that venous system. That portal hypertension then produces ascites because the increased pressure allows fluid to leak out into second and third spaces. The spleen becomes enlarged, and that destroys red cells, white cells, and platelets. You end up with varicose veins in unhealthy places, particularly the esophagus, where the vessels are extremely fragile and subject to injury, even just eating food. Hemorrhoids and the superficial abdominal veins are examples of varices that occur. So that's the portal hypertension part. There are other things that add to the ascites and the edema that have to do with the liver's ability to do its job, in particular lack of albumin. But anyway, if we take it down this track here, with the liver necrosis, liver cells that are damaged will not be able to metabolize the bilirubin correctly, so you end up with an increased bilirubin in the blood and jaundice, decreased bile in the GI tract because the liver produces bile, which drains into its tiny bile ducts and end up coming down the hepatic duct, either going to the gallbladder where that bile is stored and or moving into the intestine. So when that doesn't happen, stools become light colored. You don't have vitamin K absorption because you have to have bile to have that happen. That produces bleeding tendencies, increase in your PT and INR in particular. Bilirubin goes up in the urine because it's not going in the GI tract, it gets absorbed in the bloodstream, and that discolors your urine. On down here, you have decreased metabolism of protein, carbs, and fats. You may have problems with hypoglycemia because the liver doesn't do the glycogenolysis like it should. You have plasma proteins that decrease, promoting the ascites and the edema that I mentioned earlier. The liver is responsible for degrading the various hormones, so you have increased levels of androgens and estrogens, which produce various symptoms. You have increase in the antidiuretic hormone and the aldosterone, which also promote the edema. All this ends up producing liver failure. Your biochemical changes are the enzymes that tell us that the liver is being injured. The blood bilirubin goes up, the low serum albumin, the PT elevations, and the elevated alkaline phosphatase. Those are your blood markers. As the liver fails and cannot break down the byproducts of protein metabolism, you end up with increased ammonia levels, producing encephalopathy, hepatic coma, and eventually death. That is cirrhosis in a nutshell. Let's move on to liver cancer. Liver cancer is the fourth most common cancer in the world. Now, they're not referring here to metastasis. The liver is also a place where a cancer from another source will travel to. Primary liver cancer is the fourth most common cancer. And hepatocellular cancer is the most common. It's the seventh most common cancer in men and the ninth in women. The other are bile duct cancers. This is what a liver cancer looks like. You can see all these little spots. The manifestations of liver cancer is going to look a lot like cirrhosis. They'll do a CAT scan and MRI. The serum alpha-fetoprotein levels are elevated in most people who have a hepatocellular cancer. Cirrhosis is a risk factor, regardless of the type of cirrhosis. 50 to 60% of the time, it's the HCV. HCV is responsible for about 50 to 60% of all liver cancers, and your HBV is responsible for about 20%. There's an increase in incidence because there's an increase in the incidence of HCV. In general, metastatic liver cancer is more common than primary. Liver cancers can cause hemorrhage and necrosis, and again, the symptoms will be very similar to cirrhosis. They'll do a liver biopsy to get a diagnosis, in particular if there's not a cancer elsewhere. Your lab book talks about the care of the patient with a liver biopsy. Liver transplantation. The leading indication is chronic viral hepatitis. Another reason for liver transplantation is congenital biliary atresia. This happens in babies, and we'll talk about that a little bit. Hepatic malignancy, if they can get rid of the cancer, if it's not a metastasized cancer, that patient may be a candidate for a liver transplantation. The fulminant hepatic failure, which happens to patients who get hepatitis B plus hepatitis D, patients who have chronic end-stage liver disease, those are our candidates. There were 6,500 liver transplants done in the year 2005. A cadaver is a donated organ from a person who's died. What's interesting is that the liver can be split based on the size and the health of the donor. So sometimes two people can get one liver. And then you can have a live donor where only a portion of the live donor's liver is taken to transplant. There are complications that could include biliary problems, hepatic artery thrombosis, and wound infection. Post-op problems include rejection, but it's not as major of a problem as it is with kidney transplant. They'll use similar drugs like cyclosporin, targalimab, the mycophenolate, and the corticosteroids. 3-year survival for liver transplants is 75%. So we do have pretty good outcomes with liver transplantation. Post-op complications, patient has to be monitored for infection for 2 months. That infection could be viral, fungal, or bacterial, and the only sign might be a fever. There are drugs and the immunoglobulin that have reduced the rates of hepatitis B reinfection. So if the reason for a transplant is a hepatitis B, then they'll be on these drugs to prevent that virus from reinfecting the transplanted liver. Patients who have hepatitis C and get a transplant, they may receive antiviral therapy, but patients who have the hepatitis C will have a lower survival rate. The hepatitis B transplants, those work better. They seem to have better ability to control HBV reinfections. Okay, let's see. Do I want to do a little more? I think I probably need to stop with this video and give that some thought.